கொடுத்துருங்க. வந்துருச்சா பாருங்க. Very good evening to all the faculty members and all those people who have joined online in YouTube to watch this webinar on hospital infection control and OT protocols. On behalf of our Chief Medical Officer, Dr. Narendran sir, and our Senior Medical Officer, Dr. Kalpana madam, I welcome you all to this webinar. This is the first time we are organizing a hospital infection control webinar online. So this has got 8 topics and we have 3 panelists. Dr. Kalpana Narendran is the chairperson of Hospital Infection Control Committee at Aravind Eye Hospital. Dr. Jayalakshmi is an authority of hospital infection control. She holds advanced hospital infection control training programs. She is the head of the department at KMCH. Dr. Rajiv Sukumaran, who is the chairperson of the scientific committee as KSOS, has been traveling across for the last 1 decade, talking about hospital infection controls with his lovely videos. We have faculty from Aravind Coimbatore, Aravind Chennai, Aravind Madurai, and Aravind Tirunelveli, with a mix of seniors and juniors with vast experience in infection control practices. With this, I request Dr. Jayalakshmi madam to say a few words about hospital infection control before we move on to the main topics. Dr. Jayalakshmi madam, please.
Thank you very much, sir. It was wonderful the way you introduce everybody. Thank you very much. And it's nice to have a webinar online because you're in your own space and discussing the most important topic. And infection control, infection prevention and control, wherever it is, has now gained more center stage thanks to COVID. And the eye infections have been the way the ophthalmologists have looked into infection and prevention. I'm really amazed because the lot of interactions that they've had in the last few months during COVID time also, I have seen the ophthalmologists asking for more queries wherever it is, and say, because the closer they come in contact with patients with infections, suspecting COVID or with COVID, and they have to handle. Apart from COVID, in routine practice also, eye being a very, very most important organ of the body, which looks at everything beautiful around us. It's important that you preserve the good health of the eye and preventing infection for all the procedures done and the way it's been taken care of. The eye hospitals are definitely different from the other routine hospitals by the way that they, the type of procedures done, the duration of these procedures, the techniques that they are done, and the kind of sharing that they would do within the hospital, within the theaters and otherwise. So it's an absolute pleasure, and I'm very honored to be part of this very light group of academicians who are doing so much of wonderful work across the country and being part of this infection prevention control and OT protocol program. Thank you very much. And I now invite Dr. Chandrasekhar to start off with a basic introduction to infection control, so that everybody, I'm sure most of us know a lot of things, but we have to understand something on updation as well as those in line of what is required as an accredited facility and in times of COVID, and basic terminologies of infection control. Over to you, sir, Dr. Chandrasekhar. So you're muted, sir.
Thank you very much, madam, for the brief intro. This talk is going to be setting the trend about hospital infection control and how it has evolved over the period of time. Absolutely no financial interest. Even during Shushruta's time, there was emphasis on the way how we prevent infection in clinical practices and surgeries. This lady with the lamp was one of the first to say the very first requirement in a hospital is that it should do the sick no harm. That is to prevent hospital-acquired infections. If you look at hospital-acquired infections across the world, surgical site, upper respiratory infection are on top priority, and there are others which we have in that category. In the past, at high hospitals, we were only bothered about preventing endophthalmitis, and we must say we are better than the best in the world as far as prevention of endophthalmitis is concerned. But one thing which we have partly neglected is the conjunctivitis which occurs during the hospital visits. So it was predominantly the surgical patient. But apart from the endophthalmitis, we also need to keep in mind the COVID-19 pandemic and it may be there for quite some time, though we will get immunity. So as far as hospital-acquired infections are concerned, 1 in 31 hospitals at any point of time will have a hospital-acquired infection, and it is about 1 to 13% across the hospitals, according to the CDC. American Academy of Ophthalmology has given broad guidelines as to how to manage people, environment, HIC protocols, biomedical waste management, cleaning and sterilization, and antibiotic policies. So this was another study which showed over a period of time, out of 94,000 patients which were seen in the 6-year period, about ACCO was found to be the main cause for 45.5%. The conjunctivitis got transmitted, so that is usually a neglected part in most of the eye hospitals. And endophthalmitis was only around 8% amongst this whole this thing. And URI, unknowingly or knowingly, respiratory infection also spreads because of certain things like we sit in very close contact with the patient in the slit lamp and so on. So the impact of the infection control, very high cost, prolonged stay, you have the morbidity, mortality, antibiotic resistance, which is gaining a lot of importance, and antibiotic stewardship is playing a major role now in hospital infection control, and a possible long-term disability also. So this is in the background on which I would say this virus, which spreads like a stealth COVID-19 virus, has shown that by contact, by transmission through air and droplets, maybe the contact transmission is not as much now as it is seen. So with this in mind, what we have understood about hospital infection control, whether it is a hand hygiene, whether it is the distancing, physical distancing, or the PPE, all have come into force, though it has been existent as part of hospital infection control. People have realized how important it is. All those pandemics have been teaching us lessons. These are not new for us. The very fact that the plague doctor, sometime, so many centuries back, was seen as hazmat suit, hazardous material suit. Even in those days, you can see the hat, you can see the beak, which has some kind of scent to prevent the stench of a death from coming into the nose. The history of hand hygiene, we owe it all to this Ignace Schimmelwest in 1800s, and now hand hygiene is the foundation of hospital infection control. This is the gloves which came from Charles Dunlop, who patented the vulcanized rubber, and then the surgical mask, but the first one was the cotton gauze in 1900s. Though we talk about hospital infection control, I must say the NABH, whether it's the entry level or accreditation, has given a further push into hospital infection control, and right from the hospital infection control to the person who cleans the hospital, biomedical waste management, everything is got so much fine-tuned. Basically, we do not want an infection to spread from a patient to an employee or an attendant. That is the basic. This was the universal precaution. Every patient, every blood or body fluid, all use unsterile needles or sharps are to be considered as infectious. But what has happened in COVID-19 times, it has changed. The evolution of standard precautions is body substance started in 1897. That was the earliest part. Then it got further fine-tuned in 2007. CDC guidelines were given exclusively for OP patients also in 2012. So now it is evolved. So if you look at the hospital infection control, there are so many things that happen, hand hygiene too. So many of the most important things will be discussed in this webinar, and some of them have got modified during COVID-19 times. All these are various protocols. If followed perfectly, our hospital infection control practices will be 99.9%, if not 100%. But there must be a passion of doing it rather than as a duty. And definitely the most important word in all this is the teamwork. I thank you all for this opportunity to give a talk. I hand over to the panelists, please. Thank you.
Dr. Chandrasekhar, that was a fantastic introduction to this topic. You covered everything, saying what are the important things. And what we have noticed is after this COVID, the conjunctivitis incidence has come down drastically because we are following so many steps which we are supposed to follow. Earlier, we didn't do it. And without wasting time, we'll move on to the next topic, is standard precaution and protocols by Dr. Mangala. Over to you, ma'am.
Thank you, sir. Good afternoon, everybody. I thank the team and the panelists for giving me this opportunity to talk about the standard precautions and protocols. So standard precautions are meant to reduce the risk of transmission of bloodborne and other pathogens from both recognized and unrecognized sources. All healthcare workers will have to assume that every person is potentially infected or colonized with an organism that could be transmitted in the healthcare setting. So we are going to deal all these things, and we have to have a protocol so that it will be followed universally. So in hand hygiene, we have two main aspects. One is the moments when we do the hand hygiene, and second one is the steps of hand hygiene. So whenever we are touching a patient, whenever we are going to do a procedure, after touching a patient and after touching the patient's belongings, we have to do the hand hygiene, hand wash. And these are the indications for hand washing and hand antisepsis. Contact with blood and body fluids, handling patients, handling contact lenses or any other equipments before and after eating, to the restrooms, to the computers and other equipments, before and after usage of gloves, and even after you sneeze or cough into the hands. So when you wash the hands normally, these are the main area, most frequently missed areas. The red colored ones are the most frequently missed areas, and the blue colored and the skin colored are the less frequently missed areas. To avoid this, WHO has recommended 8 steps in hand washing, which we all know, and we are following that. So coming to the environmental cleaning, all the housekeeping and nursing staff should be trained in cleaning protocols. All the frequently touched surfaces should be cleaned regularly. Waste should be disposed in the proper color-coded bins, and all these things should be scheduled, and and the checklist should be maintained, and it has to be checked periodically. Coming to the PPE, as sir and ma'am was saying, now because of this COVID era, this completely changed, and we have moved on to a complete PPE, and this involves gloves, masks, goggles, face shields, aprons, and gowns. So depending upon the work profile, appropriate PPE was worn before, but now because of this COVID, we are using a complete PPE. So key points in PPE are: we have to wear it before any contact with the patient, generally before entering the room. Use it carefully to prevent spreading contamination. After the task is over, remove the PPE carefully and discard into the receptacles provided. And the very important thing is doffing is more important in this time than donning. Immediately perform hand hygiene before going on to the next patient. So PPE is recommended when touching blood, body fluids, secretions, excretions, any procedures, and involving the clothing, exposed skin, and secretions. So wear the PPE appropriate to the situation, procedure, organism, present or potential exposure. Coming to the linen, in the hospital setups, we have to have a proper segregation of the soiled linen and the unsoiled linen. So we have handling, transport, and process used linen in a manner which prevents skin and mucous membrane exposures and contamination of clothing. It is also done to avoid the transfer of pathogens to other patients and the environment. So if the linen is soiled, it has to be treated with 1% sodium hypochlorite, and it has to be then cleaned properly. Soiled linen is very important to be segregated, sorted, and do not mix with the normal linen. So what don'ts we have, we should not do in linen sorting is: do not rinse or shake or sort linen when it is removed from the bed or trolleys. Do not place the linen on the floor or any other surfaces. Do not rehandle the linen. Do not overfill the laundry receptacles, and do not place in inappropriate items in the laundry receptacle. Coming to the needle stick injuries, to avoid this, do not recap, bend, break, or hand manipulate the used needles. All the safety features have to be followed, and it has to be placed in the puncture proof containers. So whenever it has happened, prompt reporting and testing is very essential. Counseling, treatment, and follow-up of the particular person who got the needle injury should be correctly followed up and monitored. Coming to the pre-exposure prophylaxis, hepatitis B vaccine is recommended for all healthcare workers. Chickenpox vaccine is recommended to people who live in groups and in groups like in hostel, etc. Typhoid vaccines can be given to people who handle food. So canteen workers can be given typhoid vaccine. Coming to the post-exposure prophylaxis, The assessment of the infection rate, it depends upon two main factors. One is the category of exposure, how bad it is exposed, mild, moderate, and severe, and source of assessment of the patient, HIV negative, or low risk, high risk, or unknown. So if a patient, if the person has got a needle stick injury, then wash and irrigate the particular area. Do not get panic. Then all the post-exposure prophylaxis should be initiated in the 0 hour. Within 2 hours is good, and at least within 72 hours it has to be done. So the person should be counseled for post-exposure prophylaxis as soon as possible with consent and other things. And we have to assess the source of the patient about his ARV status, etc. Then the lab evaluation of the patient as well as the source, person exposed, and the source, check the immunization status and blood test to be taken. Then after the post-exposure prophylaxis, monitoring and follow-up is very essential. Record has to be maintained properly. The HIC nurse should keep in contact with the particular person weekly basis, and HIV test to be repeated and 3 and 6 months. Patient care and equipment, this is very important in a hospital setup like us where we use a lot of equipments. So this is very important because to prevent the transfer of microorganisms to others as well as the environment, because the microorganisms can live in this particular surface or the equipment for days, weeks, or months. So the preventive measures are followed in a consistent manner for each patient, no matter what is the diagnosis. So we have to follow the manufacturer's instructions, and clean SOPs has to be made for each instrument, which will be dealt in the subsequent talks. So this is waste disposal. This is also going to be dealt in the subsequent talks elaborately. And coming to the respiratory hygiene and cough etiquette, always instruct the person to cover the mouth, nose while coughing, and put the used tissue in the garbage. And this has now become, because of this COVID era, all are wearing masks. And so this is, and even if the patient is having a coughing, they can be instructed to cover their mouth and nose, to use tissues and dispose in no touch receptacle, observe hand hygiene after soiling of hands, and wear a surgical mask. So points to be remembered in safety procedures and protocols is promoting these protocols offers safety climate in infection control and prevention. This standard precaution should be the minimum level. It has to be followed in the precautions observed. Source control measures for all persons with respiratory symptoms through promotion of respiratory hygiene and cough etiquette. I have a few videos on spill management, needle stick injuries, and hand washing. So if a spill happens, the person is wearing a PPE, and the area is marked. The freshly prepared 1% sodium hypochlorite is taken. Others are sent outside. It's poured over the soiled area. Wait for 15 minutes. Soak using a tissue. It has to be in the red color bin. And regular, then after that, regular mopping. So how to recap a needle? Sharp instruments, how to handle a sharp instrument. Ideally, it need not be recapped. We can directly throw it away in the sharp containers. If at all it has to be recapped, this is a wrong method. You should not keep it in the hand. The right method is the cap is kept over the table and then it is recapped. If a needle stick injury happens, do not panic, do not squeeze. Just wash with sterile water, soap and water. Sterile dressing. And then as we were discussing about the consents, ARV status of the patient, immunization status of the person who got infected, everything should be noted. Follow the protocols. This is a small video about hand hygiene, steps of hand washing, soap or alcoholic hand rub, palm to palm with. Make sure that all the areas are covered. Thank you so much.
Thank you, Dr. Mangala, for that wonderful talk. You almost covered the entire topic in just 10 minutes. It was fantastic. And what is important in this difficult time is the mask. It has to be emphasized again and again. The mask is very important as far as COVID is concerned. Shall we move on to the next talk? It will be by Dr. Ram Mohan. He's going to talk on cleaning and disinfection. Over to you, Dr. Ram.
Good afternoon. Good afternoon. I hope all of you can see the slides.
Yes, very much.
So it's continuing from the basic introduction to standard precautions by Dr. Mangala is a very important topic for all hospitals, but definitely for an eye hospital, is the criticality of cleaning and disinfection and some aspects of sterilization protocols. We all know that there's increasing evidence to show the contribution of the environment or surface in disease transmission, and therefore comprehensive disinfecting regimens are required to reduce the risk of acquiring a pathogen from the healthcare environment. Infection risk classification, we all know this, but based upon that risk, we have to determine which is the appropriate protocol or methodology for cleaning and disinfection. It's a high risk which requires cleaning, disinfection, followed by sterilization, should be adequate. Every hospital is required to maintain protocols for this. You can customize it. And it's understood that the training of housekeeping and nursing staff is essential in not only following these protocols, but also monitoring and auditing. Disinfection of frequently touched surfaces is recommended daily or more frequently. And of course, waste disposal and cleaning and mopping has to be monitored too. Waste disposal in detail will be given by Dr. Shiv Kumar. Some of the definitions, sometimes we inappropriately use them, but to understand these, antisepsis is just inhibition, the growth and the multiplication of microorganisms, and antiseptics are those which are applied onto the living tissue or skin to reduce the possibility of infection. Disinfection is cleaning of an article of some or all potential pathogenic organisms. And a disinfectant is any antimicrobial agent applied to non-living objects to destroy the microorganisms. And last but not the least, fogging is a methodology of sterilization of air or the environment with the help of gas or a vapor. Fumigation is being used. Which is not recommended anymore. A brief on the types of antiseptics and disinfectants. We know that they can be grouped into either bacteriostatic or bactericidal. And you look at it, both are actually used, but bactericidal ones are the most frequently used in a hospital setup. Iodine, povidone iodine, the alcohols, and chlorhexidine. The alcohols are very broad spectrum. And of course, we have 3 of them which are popularly in use. They're effective with gram-positive, gram-negative, as well as fungi, viruses, and spores. The efficiency varies whether you use IPA, ethanol, or propanol. And exposure time also accordingly varies, and you can decide what you require for your setup. Chlorhexidine, again, is effective, broad spectrum, damages the DNA in cell wall, is often used in hand scrub as well as various types of body washes and solutions. And it has 2% is the one that is most frequently recommended, and 0.5% is used in instrument disinfections. Iodine, again, generally used as betadine or povidone iodine. It works very well and has very powerful antimicrobial activity. And in spite of its limitations, it is still the disinfectant of choice for pre-op prepping for surgeries. Outpatient instruments and equipment and devices need to be frequently cleaned and disinfected. And the reasons are quite evident. In summary, we know that microorganisms survive on surfaces for quite a long time. And we have noticed over the last decade or 2 decades increasing incidence of MRSA in the general population, as well as multi-drug resistant gram-negatives. ACCU is a problem and still continues to be a problem in many hospitals. And prevention measures are followed in a consistent manner for each patient, no matter what the diagnosis. So protocols for cleaning and disinfecting of equipment, 3 criteria. 1, of course, follow the manufacturer's instructions. If not, follow the best practices as recommended. Design and develop your own SOPs for each instrument, and make sure this is plugged into your appropriate manual. For example, in the HIC manual, this gives an overall protocol for various cleaning and disinfecting of various OPD equipment. We also need to have SOPs for frequency of disinfection of various environments and surfaces. And the one given over here gives us the algorithm that we are using for our OPD and wards. And for example, in the clinical units, we are using chlorhexidine isopropyl alcohol recommended between cases. And for the floors, 5% Lysol and 3 times daily. And if you noticed carefully, this protocol is actually one which was modified for our COVID times. And we may choose to continue this for a medium term, long term. Next is cleaning and disinfection pertinent to the operation theater. And for this to happen effectively, the CSST staff needs to be on top of things. They need to understand the science and technology of the equipment, the instruments. Application is safe handling of all items that need to be disinfected and sterilized. And of course, SOPs and validation procedures for all these processes. The microbiology plays a very important role over here. And this all gets plugged into the hospital infection control policies. A similar algorithm for OT disinfection. For example, the floors, the corridors, the OT and the instrument washing room, etc., we use 5% Lysol. In the operation rooms, between every 2 cases, in other areas every 1 hour, and in the CSST itself 3 times daily. So cleaning and disinfection with respect to instruments used for the operation for surgeries is to prevent contamination of sterilized materials and to prevent post-operative infections due to contamination. Certain things need to be done at the end of the day and certain things need weekly cleaning. Floors and wall cleaning. Some of the points on this is, of course, remove all biomedical waste before you start any cleaning process. Clean the walls with surface disinfectant from top to bottom, sweep towards the door, scrub the corners and tile joints, use a vacuum cleaner where necessary, and of course all handles and glass inserts with a moistened cloth. Remove stains using a scrubbing machine, and floor mopping, the recommended method is the 3-bucket method. And in situations where you don't have a filtration or HEPA filtration modular systems, fogging can be carried out. A very good video on this is available in the public domain, as also via AOS. and that is gratis Dr. Rajiv Sukumaran. Some of the chemicals which are used, popularly used for fogging. We have, of course, fumigation using formalin has been banned, and even though some hospitals continue to use it, we highly recommend that they don't do. The chemicals which are popularly used are divided into three groups, the glutaraldehydes and the chemically bound formaldehydes. Then a wide variety of the quaternary ammonium compounds, or a combination of glutaraldehyde and quaternary ammoniums, and the ones which tend to be used for those hospitals which are doing fogging or the oxidizing agents, particularly hydrogen peroxide. The cleaning of surgical instruments plays a very important role. I'll just go briefly over the pictures. Initial cleaning, pre-cleaning and post-cleaning after ultrasonication, followed by thorough drying. Phaco handpieces and sleeves require special care, and absolute drying is necessary before you load it into the ethylene oxide sterilizer or the autoclave. We will try to capture some of these key steps in this video over here. You have to use a soft brush. Please keep this submerged so that you do not generate splashes or aerosolization. Followed by sonication. And back to the 3 basins of RO water. Very essential to dry each of these instruments. Lumined instruments like the phaco and IA tips need to be flushed. There are recommendations as to what volume and what type of fluid you require to use to flush these. You may use an air gun to dry these lumens on the surface. Next comes the use of chemical indicators for sterilization, which will be the next process after thorough cleaning and of the instruments. The need for indicators is very clear. Each of the test systems reveal a change in one or more of the predefined variables based on either a chemical or a physical change resulting from exposure to the process. For example, color change. The ISO classification of type 1 to type 6. Some are external indicators and some are internal indicators. I'll briefly go through some of these. Before that, before you load anything for sterilization, some of the key things that we need to know is that all debris and soiled instruments need to be thoroughly cleaned before for packaging and sterilization. All debris, inclusive of visco elastic, should be removed from the instruments. Keeping the instruments moist may be a good idea to avoid drying up of debris and the viscoelastic. A dampened lint-free cloth or a soft brush should be used to clean instruments in accordance with the manufacturer's recommendations. Flushing the instruments preferably is initiated in the OR and completed in the decontamination area. And as I mentioned earlier, minimize the splashes and aerosolization. If you're going to reuse brushes, please clean and sterilize at least once daily. And of course, instruments should be visually inspected for debris and damage after cleaning and before packaging for sterilizing. There's always been a doubt use of enzymatic detergents, but the current recommendations are that these should not be used routinely, and inappropriate or incomplete rinsing can result in TAS. The ultrasonic machines that are used need to be emptied, cleaned, disinfected, rinsed, and dried at least daily. With respect to reusing of phaco tips, the advisory is that cataract surgeons have the discretion to decide on this based on their clinical observations and judgment. For some time, we were using the term flash sterilization, and in some situations we can use this. But to differentiate this, a new terminology has come called immediate use steam sterilization, and that's not the same as a short cycle sterilization. IUSs can be used on an emergent basis to provide instruments to the OR for a surgical case that is already ongoing. Okay, so to the type 1 indicators, this is nothing but your color-coded tape. And of course, this can also come in as a documentation label or as a gun. These are intended for use with packs or containers to indicate that they've been directly exposed to sterilization and to distinguish between a processed and unprocessed units. This has to come on every item. Type 2 indicators are for specific tests. The bovidic has to be included prior to start of any autoclaving process. The helix test is used as a hollow load release for illumined instruments. The type 4 is a multivariable indicator, and we have a variety of these for steam, ETO, or for plasma. Integrating indicators are also there, and they show various color changes based upon exposed, unexposed, or extended cycle pass. The biological indicator is a test system containing viable bacterial spores. It provides a defined resistance to sterilization process. It's advisable that the indicator is run each day that a sterilizer is used. The type of cycle can also be monitored with the biological indicator, whether it's a high vacuum or a gravity or extended cycles. Instruments and items which cannot be autoclaved can be ETO sterilized. There are certain advantages to ETO sterilization, but most importantly, it's a very common gas sterilant. It's available as various mixtures. It's very effective in clean microorganisms. It penetrates medical packaging and plastics very easily. It's compatible with most medical materials, and the process is easily controlled and monitored. Some pointers in this is that first, dry all items thoroughly before packing, and seal the materials in the individual Medipeel packs. After placing the appropriate indicator labels, check the pouch for damage or leakage, load the items. And after placing the cartridge and post-sterilization, verify whether the indicator has shown appropriate color change. And of course, it's essential to document all indicator and machine printouts. The plasma sterilization is a new thing in the market. Is quite often being used internationally and a few places in India. A lot of advantages for this, but it's a little more expensive and a little more complicated to understand. Last point is regarding documentation and guidelines. The recommended documentations and required are the chemicals manual. We strongly recommend each hospital generate its own manual for the various types of chemicals that they are using, and MSDS for each of the chemicals in use, including disinfectants. The OPD and OT cleaning and disinfection SOP should be included in the HIC manual or the CSST manual as appropriate, and microbiology surveillance should be registered in the CSST registers. Guidelines for OPD cleaning and disinfection, the latest ones recommended through the American Academy of Ophthalmology 2017, as well as the HICPAC from 2008. OT sterilization guidelines, most recent task force, the OICS task force, the guidelines for cleaning and sterilization of intraocular surgical instruments is the one that is recommended. And the latest infection control guidelines are from January 2020 from the Ministry of Health and Family Welfare. Thank you.
Thank you, Dr. Ram, for that exhaustive talk on cleaning and disinfection. In fact, he took up Madam's topic also a little bit on validation and surveillance. He spoke about the indicators, and now we'll move on to validation and surveillance. Lalita Madam is going to talk on that. Over to you, ma'am.
Thank you, sir. Yeah, I would like to start by congratulating and thank Dr. Chandrasekhar sir for continuing this program. Last year, I remember we had it live in Coimbatore, and it was a very nice response with a lot of OT technicians and nurses had attended, with equal ophthalmologists also attending. So this is a very good platform now to reach out to a wider audience to have this topic. So coming to my talk, which is microbiological surveillance and validation. So now this is the most important evidence that we are going to have to show that all our protocols, cleaning, everything is in place and it has been properly done and everything is working. So the proof of what we are doing will come only when we test for it, and that is through the microbiological surveillance. Now, before I go into that, I just wanted to talk about just one or two slides on what actually are we trying to achieve with all this. So especially for ophthalmologists, HIC is also important, although important in other parts of the hospital. We are most concerned about endophthalmitis. So all our protocols, cleaning, everything is geared towards reducing this endophthalmitis. And so it will be good to remember where and all are the sources from which endophthalmitis can come, especially since there are a lot of nurses and other paramedical staff listening to this talk. It will be important to know. So first, risk factor, if you know, there's so much of evidence and all of us know that the patient's own flora is the #1 risk factor. And then if there's any problem with any of the preoperative prophylaxis that we are going to follow, that could be another very, very important risk factor for developing endophthalmitis. And the surgical procedure per se, if there is a big wound and other things. And if there is any contaminated consumables among all the variety of consumables which we are using, that is a very, very important cause of cluster endophthalmitis. And then finally, coming to any of our sterilization and aseptic techniques, if there was any break in that protocol, if there was any deviation. And currently, again, this is just to refresh our memories. And for people who are not aware, it's very, very important to know what is the current incidence of endophthalmitis, postoperative endophthalmitis that we're talking about. It is about 0.01 to 0.07%. And obviously many hospitals might have even zero incidence of endophthalmitis. So if you have that incidence in mind, and then monitoring after that becomes more meaningful. And then again, what is this sporadic and what is cluster? So sporadic is, all of us expect it to happen 1 or 2 cases in a year or in a few months. But cluster is what all of us are really afraid of. And this can really happen because of all these consumables, which I was mentioning here, can be a little bit of contamination. And especially if you deal with organisms like Pseudomonas, fungal infections, gram-negative infections, all these could point to a source of common contamination, which could lead us to clues to look for which could be the source of that infection. Now, coming to the microbiology surveillance, now again, so much importance is and emphasis is placed on this. Again, I said because this is the evidence that everything what we are doing is being done correctly. So when should we do this? Again, for OT people, it's very important to realize this. So we have one full category which we do routine surveillance, weekly, monthly, yearly. And then whenever a hospital is undergoing construction or undergoing remodeling, it's very important that immediately you finish all these activities. Again, you have to do a surveillance again. And then especially if there has been an outbreak. So this we are very familiar. So many news items comes out in the paper. This has happened, that has happened. And then we start to check for each and everything in that operation theater. So that is a different kind of surveillance that we do. And then as Dr. Ramohan also is mentioning, the CDC website has got a lot of information on how to go about doing all this. And then also just one slide on what the NABH tells us. So actually there is not any like a textbook or any prescribed this thing on exactly how to do it. So according to the COP 10 standard 10, what it says is documented procedure guide the care of patients undergoing surgical procedure, and the operation theatre should be adequately spaced and monitored for infection control practices, and quality assurance program and surveillance should be in place, and surveillance activity should be all these things. In addition, the efficacy of OT cleaning and disinfection process shall be monitored. So that is what the NABH standard tells about this microbiological surveillance. So it doesn't actually spell out the actual exact way of doing it. So the microbiological surveillance and validation is normally we do it only for the air, and that is in the operation theatre air cultures we do, and the checking for the air conditioning filters. When it comes to water, we have to check both for the quality of water and also for the microbial load in the water. And then also surface cultures like the wall equipment, etc. is also sometimes required, although they really actually don't contribute to the development of endophthalmitis. And then finally, validation is the only validation which we have to do in the operation theatres for the autoclave indicators. So coming to the air, so the air actually depends upon the type of air conditioning which the operation theatre has. And there's so many, this is a separate talk by itself, and so much information is available on the types of air conditioning. So whether it is a laminar airflow with HEPA filter or it's a wall mounted, and air quality is routinely most commonly tested by the settle plate method. So that's the most easiest to do and most easily available. Whereas a volumetric method, it's more for an industrial pharmaceutical companies, they do it. So OT surveillance recommendation once in 15 days, or at least minimum of once a month, definitely it has to be done. And if you have a HEPA filter with a laminar airflow and all, the filter can be checked once a year by the company person and validated. Now coming to the water plays a very, very crucial role in our activities, what we do, especially in an ophthalmic theatre, because there's a lot of contact with not the actual water, but the components of the water have this thing to get into the eye. That is, I'm talking about the endotoxins and the salts and other things which could be in the water. So water we use most commonly is hand washing, cleaning instruments, and also inside the autoclave, the water which we pour. And so what are the different sources is normally UV filtered, RO water, distilled water, different types of sources of water can be used. And it's good if you can have a separate water source where it can be cleaned and it can be monitored, and this filtration systems and all can be well maintained. So culturing of water is definitely monthly, and the quality of the RO also should be done monthly, where all these other like total dissolved salts, sediments, chemicals, all that can be tested, including the endotoxin level also. Autoclave indicators and documentation, since Dr. Ram Mohan has covered it in depth, I just have one slide which just shows all these things in one shot. But most important point to remember is, this is the only proof we have even a few days or a month later that a sterile set has been used for the patient. So it's very, very important that all these indicators are maintained regularly in your registers. In the first place, you have to use it wherever it's supposed to be used, and make sure that the indicator has done the function and the color has changed, and that has been documented in your register. So this is, in case of any trouble, any problem, this is the first thing anybody would check. And it's very, very important that all these are maintained for the specified period of time. So class 1 indicator, which is actually a process indicator, and a class 2 bovedic, class 5 or 6 is every set, and biological indicator weekly. And final slide. So I wanted to conclude this talk by finally saying what to do in case of unfavorable reports. Especially in our hospital, if you say like fungus is grown from the theatre, first thing they'll do is call me back. What to do, madam? What to do? So that is a very this thing that everybody can learn not to panic. And it's especially in this kind of climate, you might see 1 or 2 fungal colonies. It doesn't matter. repeat the cleaning and fumigation if needed, check the AC conditioning, air conditioning filters, because that is a very, very potential source for all these air contamination, and repeat the culture if needed. And finally, what is most important is the documentation and the record keeping. And you can have n number of records. It's only you can err on the maximum rather than having minimum number of records. And more important, maintaining the records is the reviewing of the documentation and monitoring by the HIC committee or the CSSD team or whoever's responsible. Very, very important that this has been monitored and the information shared with everybody. Thank you. This is how our Tepakulam is looking nowadays in Madurai.
Beautiful, madam.
Thank
you, madam. As usual, a fantastic talk it was. Very nice, very informative, and very simple it was. If people who are watching in YouTube, if you have any questions, please put it up in the chat box. We'll have it at the end of the session. After all the talk, we'll take up the question and answer them. And we'll move on to the next topic. It is biomedical waste management. It will be dealt by Dr. C. Shivakumar. Over to you, Dr. Shivakumar.
Good afternoon. Are my slides seen? Afternoon.
Yes, it's visible.
Okay, fine. Thank you. I'm very grateful to Nailan sir, Kapna Madam, Chandrasekhar sir for this opportunity to present about biomedical waste management. And I start with all these warning symbols of biohazard, cytotoxic waste, as well as radioactive waste. So, to define biomedical waste, it is waste generated in the diagnosis, treatment, or immunization of humans or animals in research, or in the production or testing of biological products. And in that, the hazardous waste constitutes about 20% of the generated BMW, and it is that which has the potential to pose a threat to human health or life. To get an overview of the amount of BMW generated, it was about 550 tons per day in 2018, at an average of 1 to 2 kgs per bed per day. So why is biomedical waste risky? Because of the hazards that it can cause to the housekeeping worker, medical and paramedical staff working in the hospitals, to the patients and attenders coming to the hospital, and in general, if not disposed properly, a danger to the public, especially scavengers, cattle, and also to the environment like air, water, and soil. Such sites were not uncommon till long back, and the first serious measures started being taken in 1998, though initially it was started in 1986. The first laws for biomedical waste management was started off in 1998, and the recent has been the Act of 2016 with 2018 amendments. So the sites covered in the recent rules are the hospitals, nursing homes, clinics, and recently included also the camps, surgicals, or diagnostic dispensaries, blood banks, pathological laboratories, and also the veterinary institutes and research laboratories. So classifying biomedical waste, 80% is non-hazardous, and among the rest 20%, 15% is infectious, with sharps, non-sharps, and liquids included. And other non-infectious are the 5% radioactive, cytotoxic, broken glass, which will cause physical injury. So the entire process of biomedical waste management goes through generation and segregation, collection, and then transport to the interim storage, and from there to a common transport to a common biomedical waste facility, and thereafter from there a terminal treatment and disposal. So in 1998, the biomedical waste was categorized into 10 in the following sequence: human anatomical waste, animal wastes, microbiology and biotechnology wastes, sharps, discarded medicines and cytotoxic drugs, soil waste, which is like soil cotton, dressing, plasters, solid waste, which are disposables other than sharps like tubings and catheter, liquid waste, the incineration ash from the final terminal disposal, and the chemical waste. So what is most important is that generation can be reduced by purchasing reusable items and using them to the maximum, which is made of glass or metals which can be re-sterilized. Having a strong recycling policy and selecting non-PVC plastics to reduce the damage to the environment. Segregation should happen at the point of generation and always by the employee generating it. And so it's essential to train every employee about the BMW management. And this segregation should be done in the prescribed color-coded bags. The BMW bags, bins, and containers should always carry the biohazard symbol. And the plastic color-coded bags and containers should be non-fluorinated, which is a recent addition, and should be bar-coded, which is coming in the 2016 Act. Bags or sharp containers should never be filled to the full, but only to 2/3 of the capacity. So what goes into what? For yellow, it is the anatomical waste, infectious waste, material contact with blood or body fluids, gowns, microbiological and laboratory waste which has been treated, and also discarded or expired medicines and cytotoxic medicines. So these are all things which can be incinerated. Whereas the red contains plastics which cannot be incinerated, like the syringes, IV tubes, pouches, drains, urine bags, and other items. The blue need not be a bag. It is actually a cardboard box with a blue lining to identify the glass bottles, ampules, vials, and also the metallic implants. The sharps container contains needles, plates, and knives. General waste, of course, does not come under biomedical waste, but they are the recyclable ones like paper, pens, plastic, etc., and biodegradable like fruit, vegetables, and food. In order for a good compliance, it is essential and mandated for the posters to be put bilingual in English as well as in the colloquial language so that everyone can follow. These are the bags and containers, and here you can see about the recent change in the sharps container, which has got a broad lidded, translucent, thick plastic, puncture-proof container. And this is the blue lined cardboard box in which the glasses and metal implants can be done. What generally gets neglected is the waste management, and this needs to be treated or decontaminated before the effluent is released into the sewage. There's an immediate danger due to the pouring of the liquid waste into the basins where there can be a splash or there can be aerosolization, because of which you can have aerosolization, because of which there's a direct hazard to the person handling it. And moreover, if it is released into the sewage, it can cause water pollution. This liquid waste is treated with 1% sodium hypochlorite with an exposure time of minimum 30 minutes. Other disinfectants, which are now recommended because you should use non-fluorinated ones, are aldehydes, 70% isopropyl alcohol or ethanol, and povidone iodine 5%. And what has been recommended recently by the government is passing it through a UV sterilizer. We can have either cisterns or we can have the large hospitals with a large amount of liquid waste can have effluent treatment plants. So you can either have a small disposal unit, you can have an automated unit, you can have a large tank which can dispense sodium hypochlorite into the tanks where the water is collected and then goes into sewage. And you can have an effluent treatment plant. Another waste that requires pre-treatment is the laboratory waste, and that's because it is potentially very infective. The laboratory waste like cultures, culture media, specimens, blood bags, and all need to be sterilized by autoclave or microwave before being disposed, achieving a log 6 reduction, and then it should be disposed in the yellow bag. Alternatively, a chemical disinfection can be done, decontamination can be done with 5.23% sodium hypochlorite, with a holding time for 8 hours to achieve a log 4 reduction, or non-chlorinated disinfectants like aldehydes, phenol, or ozone. The BMW bags, as I said, should be filled only up to 2/3. It should be securely tied and tagged with a label mentioning the area of collection facility, the date of collection, the type of biomedical waste collected, and signature of the sister in charge. The handling of the BMW by the healthcare workers who transport the bags from the area of collection to the interim storage area should be appropriately trained, should be provided, and they should wear the appropriate PPE, which includes the gown, the mask, cap, and safety gloves, and gum boots in order to cover the entire foot and the knee and ankles. And they should be vaccinated for hepatitis B and tetanus. The internal transport should be in a trolley, which is loaded and taken to the storage area by the healthcare worker, always in a PPE. The trolley should not be open, should be closed and with the biohazard symbol. It should not be overloaded like this. The trolley should not pass through patient care areas. And the dedicated trolley is to be earmarked only for biomedical waste transport, not to be used elsewhere. And while it is being transported, there should be no space. The storage area should be isolated from the patient care areas. It should be remaining always under lock and key. The biomedical hazard symbols should be displayed or stuck outside the door. And there should be a facility of hand wash for the healthcare worker who is handling it. There should also be a facility to watch the trolley, and there should be easy access to the transport vehicle. The transportation to the common biomedical waste treatment and disposal facility is done in closed vehicles having a biohazard symbol and a record of weight of each category of biomedical waste from the facility is maintained by both the parties, that is the occupier as well as the treatment center. In the latest amendment, it is a requirement to have a geopositioning system in order to geo-track with a mobile app, and there should be a report of any mishaps to the institution as well as to the common treatment plan about any spillage, any accidents like spillage or fire or even road accidents. So finally, in the terminal, let's look at the terminal treatment in the common treatment facility. All that has been in the yellow bag, anatomical waste, soil waste, and treated lab waste are incinerated, and the ash is buried deep in the landfills. As far as solid chemicals are concerned, they are kept in yellow bags and liquid in the yellow container. And each of these chemicals should be separately labeled so that they can be identified by these tags, and then they can be treated and let into the sewage, especially the liquid ones, or they can be incinerated, or they can be handed over to the hazardous material disposal facility. As far as the medicines are concerned, ideally, institutes should be handing it over to the manufacturer before the expiry date. And discarded medicines can also be can be disposed of by incineration if possible. The red bag contents like tubings, catheters, and syringes cannot be incinerated. They first need to be decontaminated by the autoclave or microwave, and then mutilated and shredded. And plastic pellets are made out of it, which can be used for, which can be reused. As far as the sharps are concerned, they are again decontaminated with autoclave or microwave, and then mutilated, shredded, and buried in concrete pits or handed over to the steel foundry. The contents of the blue-lined cardboard box, broken glasses can be buried deep. The other glasses can be washed, decontaminated, and sent for reuse. And the metallic implants can be sent again to the steel foundry. During the COVID-19, the biomedical waste management rules remain much the same. But this is for the dedicated COVID hospitals or COVID patients. The segregation and source should be done with minimal handling as usual. It should be collected in foot-operated bins and labeled as COVID on the lid. The inner and outer surfaces of the bin after the removal of the bag is to be disinfected with 1% sodium hypochlorite. The bag which is packed is tagged as a COVID tag with the healthcare worker wearing the proper PPE during disposal. It can be kept separately in the storage room. And this can be sent separately so that there is an early terminal treatment and disposal at the common treatment plant. So coming to the recent legislations and regulations requirement, we should have an MOU with the common biomedical waste treatment disposal facility if there is one within 75 kilometers of the healthcare facility. Otherwise, our own the healthcare facility needs to be made up. It includes the surgical and other camps in the list of occupiers. Instead of the 10 categories in 1998, there are only 4 categories according to the yellow, red, blue-line cardboard box and sharps. Liquid waste management has been stressed upon, and hospitals having more than 10 beds should have installed an effluent treatment plant by December 2019. Non-chlorinated bags should be used for collection, except for blood bank bags, which is an amendment in 2018. The bags should be barcoded for tracking, Geopositioning system should be installed by the common treatment plant for tracking of transport through the mobile application. Reporting accidents, including spillage, fire, or even no accident should be reported regularly to the PCB. The annual report of every occupier has to be uploaded in the pollution control board website, and the occupier should have this data included in their own website. And the monitoring of the state pollution control board is done by the Ministry of Environment and Forests through dedicated form. So with a proper management of the biomedical waste, we can help our healthcare workers, patients to be safe, as well as the general public and the environment. Thank you very much.
Dr. Shivakumar, you dealt it so nicely, and you have covered all the aspects right from the beginning till the end, including the tagging. And we in Kerala, we have a very good system by the IMA. It's called the image system. It does each and everything what you have said. It is even geotagged also. Each bag will, if by mistake a bag drops on the way, it is tagged. And they'll let you know that your particular bag fell off the vehicle here and it has to be sorted out. And we get the message through our mobile. It's very, very nicely managed system, image by the IMA. Now we'll move on to the very important topic, antibiotic policy. That will be dealt by Dr. Premanand. It's very, very important topic. Over to you, sir.
Thank you, sir. Good afternoon, everyone. So what is an antibiotic policy? It is a set of strategies and activities undertaken to organize the antimicrobial treatment in the hospital and to achieve better healthcare outcomes for the patients. It is an evidence-based medicine knowing about the local epidemiology, and it has to be uniformly followed across the hospital. So why you need an antibiotic policy? Is it for NABH? No. So if you see the most common cause for death across the globe, antimicrobial resistant infection is the most common cause for death, even more than the cancer. So what are the causes for the death caused by these antibiotic resistance? And one of the important thing is the overuse of antibiotics and the lack of infection control practices, as well as the paucity of newer antibiotics. So how antibiotic resistance develops? So antibiotic resistance happens, suppose when you prescribe an antibiotic to a patient, and instead of giving you the proper duration of treatment, and if you over treat the patient, or in case if you are given the patient treatment for a, say for example, a 5 days duration, and suppose the patients feel better after 1 or 2 days and stops taking the antibiotics, what happens is the microorganisms which are being left out will develop resistance to these antibiotics, and those antibiotic resistant microorganisms from that patient will spread to the other patients, that can lead to an antibiotic resistance, as well as the overuse of antibiotics in livestock and fish farming, and poor infection control practices in hospitals and clinics, lack of hygiene and poor sanitation, as well as the lack of newer antibiotics. So if you want to precisely know how it really happens is, suppose when you're prescribing a drug to a particular patient, which is a suspected microbial infection, and the patient, instead of taking it for the proper whole duration and stops immediately, then the patient will have a drug resistant bacteria developing in their gut. And if the patient attends a clinic or hospital, and in case if the hospital or a clinic is not having a proper hygiene, then from that particular patient, it can spread to the other patients who are visiting the hospitals. And those patients, after reaching their home, they can spread to their other family members. So what happens if there is an antibiotic resistance? So you'll be having more amount of infections which are going untreated, and there may be excessive stay of the patients in the hospitals, which also increases the cost of the patient, as well as increases the mortality and morbidity. So as a hospital, what you can do to prevent the antibiotic resistance? So you should have a separate group or a team to handle all the antibiotic resistance things, and you're supposed to avoid cross-contamination or cross-infection from one patient to another patient by managing clean hands and instruments, as well as the environment, implementing programs to optimize antibiotic use and monitor prescribing and resistance patterns, have a dedicated resource team to tackle all these things, discharge the patients as soon as possible when they are well enough, and have a proper waste management as well as safe water and adequate toilet facilities. So how to create an antibiotic policy? So you can use an existing guidelines, which is an acceptable national or international guidelines, as well as you can take knowledge from the region where you are based on the trends in your region, as well as if you're a tertiary eye care center or a big hospital, you can use your own antibiogram to determine the trends in the particular hospital. So these are the examples which you can use to have your own antibiotic policy. And for you to have a good antibiotic policy, you need to know about the empirical antibiotics. Suppose when a patient is coming to you with the suspected infection, and if you don't know whether the particular organism is being sensitive of the particular antibiotic, you can start them on a broad spectrum antibiotic, which covers both the gram positive and the gram negative. And once you get the antibiogram as well as the sensitivity patterns, you can shift to a more specific antibiotic. So you should have an empirical antibiotic to start with and move to a first line antibiotic. And there are a few antibiotics which you have to keep it as a reserve. So only that has to be used only for the patients who don't respond to a first line antibiotics or who are resistant to a first line antibiotics. Don't use the reserve antibiotics in the beginning, so that you may not have newer antibiotics or another antibiotic which may be susceptible to the particular organism. So antibiogram is nothing but it tells you the sensitivity of a particular organism to the antimicrobial agents. So this will help you out in deciding what is the empirical antibiotic that you are supposed to use when you come across a patient. So empirical antibiotic is generally started if you suspect a bacterial infection, and you are supposed to review the response of the patient in 72 hours, and based on the sensitivity report, you can de-escalate the antibiotic from a broad spectrum to a narrow spectrum, from a combination to a single agent, a less expensive and less toxic, and from parenteral to oral route. So an antibiotic committee should include a clinician, microbiologist, an antibiotic committee, as well as an infection control committee. Actually, antibiotic committee is part of an hospital infection control committee. And a main role of antibiotic committee is to ensure effective treatment, recognize trends in the antimicrobial resistance within the institution, as well as make sure that the proper infection control procedures are being followed. So when it comes to ophthalmology, it is either a topical or a systemic antibiotic, whereas when it comes to topical, we use a fortified or commercially approved antibiotics. So, and it is better to list the antibiotic policy disease-wise as well as the specialty-wise. So I'll give you some examples. This is our antibiotic policy of the orbit. In case if you come across a patient with an orbital cellulitis or abscess, these are the first line antibiotics which we'll give. And suppose if the patient is having a resistance to those, then we have an alternative antibiotic which we use only in case if the patient is not responding to the first line antibiotics. And this is for endophthalmitis, where this is the initial intravitreal injections that we use. And based on the response as well as this culture report, if it is positive, then we'll change the antibiotics for further interventions based on the reports. So each hospital should have their own empirical antibiotic and then move to a more specific antibiotic based on the culture and sensitivity reports. And another more common scenario that we use antibiotics is for corneal infections and ulcers, where we need fortified antibiotics, which is a high concentration antibiotic which we use and is an off-label use because we don't have any approval for the use of fortified antibiotics. So the main reason for you to use is, say, you can have a wide choice of systemic antibiotics, and it increases the antibiotic concentration in the corneal stroma, which will help in the controlling the infection. But the main drawback is it has to be prepared, it has to be refrigerated, and it has a short half-life of about a week, and it is more toxic. So you have to be very careful in preparing and issuing these fortified antibiotics, and make sure a patient uses it properly and dispose it properly. And when it comes to the topical antibiotics, the most common scenario that we use topical antibiotics is the post-operative prophylaxis for any cataract surgery or any other intraocular surgery. And we have enough evidence to say that intracameral cefuroxime reduces the incidence of endophthalmitis, as well as we have our own study. And intracameral moxifloxacin also reduces the incidence of endophthalmitis by about 6-fold in phacoemulsification. So if we, in case, if we use intracameral antibiotic for all patients post-surgery, whether do they develop resistance to these antibiotics, because moxifloxacin is what most commonly we use, and that is one of the considered to be the superior antibiotic that we have currently in ophthalmology. And there have been evidence to say that since it's a single time dosage, there is less chance for you to develop a resistance to these antibiotics. So you can still go ahead with your intracameral antibiotic after your cataract surgery, which help you out in reducing the number of endophthalmitis. And another important thing which we commonly or frequently we come across is the tapering of antibiotics along with the steroids. Most of us know that the DBCS, one of the main role is to decrease the cost of the treatment, particularly for poor patients who cannot afford. They used to combine antibiotic with the steroid drops, and they'll be giving in a single bottle, and they'll be asked to taper it as we taper any steroids for that matter. But in case if you taper antibiotic, you may end up in having a resistance. So it is always better to avoid tapering antibiotics and always give separate antibiotic and a steroid, so that you can taper the steroids and you can stop the antibiotic based on your either at 1 week or a 2 week regimen. And this is one of the recent studies which has been published in the Journal of Eye in 2020, and it's a multi-center international study, and they have mentioned that 1 week of levofloxacin, they have used levofloxacin as an antibiotic topically, and they found that 1 week of antibiotic is more than enough for you to give a infection control. Another common scenario where we prescribe antibiotics is conjunctivitis, as we know that most of the conjunctivitis is virus, and it's we are mainly give antibiotic to prevent any secondary infections, but it is really not necessary. So treat the viral infection with lubricating drops and wait for the response, and based on that, if you suspect an antibiotic secondary bacterial infection, you can start your antibiotic rather than giving prophylactic antibiotic to these patients, which will increase the chance of developing resistance to the antibiotics. So coming to the take-home message, it is better to have your own antibiotic policy if you have a large hospital, or you can use other policies which has been already been there. Regular monitoring and surveillance of infection control practices, avoid misuse as well as overuse of antibiotics, and avoid tapering of antibiotics. Thank you.
Thank you, Dr. Premanand. You clearly outlined the antibiotic policies and what we need to do in our ophthalmic practice. Thank you so much for your wonderful talk. And we'll move on to the next talk, is HIC training, which is very, very important in the present scenario. That will be dealt by Dr. Shashikala. Over to you, Dr. Shashikala.
Good afternoon to all. I thank the organizing team for giving me this opportunity to be part of this webinar. For the next few minutes, we'll be looking into the topic about, as Sir mentioned, an important topic in hospital infection control, which is the training for the hospital infection control. I don't have any financial interest. So I would like to start with the Tirukkural that emphasizes on how much important continuous learning or training is in. Thottanai thoorum manarkeni maandarku katranai thoorum arivu. That means in sandy soil, when deep you dwell, you reach the springs below. The more you learn, the freer streams of wisdom flow. So coming on to the hospital-acquired infection, there is a risk of infection present in every hospital, which we call it as a nosocomial infection. It's a most dreaded adverse event associated with healthcare delivery. It accounts for considerable morbidity, mortality, and cost. It could be prevented by better quality clinical practice. So a trained healthcare worker will be able to function effectively, and they will be able to help in preventing and controlling the healthcare associated infections. So there are a lot of evidences in the literature that speaks about how important training is for hospital infection control. Study published in the Indian Journal of Critical Care Medicine about the impact of education and training program on knowledge of healthcare among the students about nosocomial infection in a tertiary hospital. They've clearly concluded that there is a need for more emphasis on training for retention of knowledge regarding nosocomial infection and reinforcement of the principles of standard precaution and hand hygiene. Another study published in Indian Journal of Medical Microbiology, talking about the impact of education on knowledge, attitude, and practice among various healthcare workers in nosocomial infection, concluded that a yearly education program on nosocomial infection and its prevention will help in retention of knowledge, attitude, and practice among the various categories of healthcare workers.
So this will help in better adherence to barrier protection such as hand washing, use of glove and hand disinfection. So this is a risk assessment cycle. So before we start on training, we need to analyze the situation. So we need to perform a gap analysis. So what is the level of healthcare knowledge in the existing healthcare control practice? What is existing in that institution has to be seen in. So we need to define the current state of skill, knowledge and abilities of the employees or the trainees. So while performing a gap analysis, we'll be able to identify what are the priorities, we'll be able to identify the causes of performance problems, we'll be able to identify what are the possible solutions, so we'll be able to match the gap. So any training success will lie in the how good we plan. So before we start a HIC training, so you need to create a training calendar. We need to list out what are the topics to be covered in the training. We need to group the staff into various categories so that they can be addressed together. And we need to identify who will be our resources, and we need to create the teaching material. We need to conduct evaluations and periodic monitoring to look for any adherence in their workplace. And this training has to be annual, as I mentioned earlier, and any breakdown situations in between or any special circumstances arising needs to be addressed and reinforcement has to be done. So this is, I've put in our training calendar. So this training program comes under our human resource. So where various trainings are being done, and part of the training is the hospital infection control training, and all the documents regarding the training has to be kept in place so that it is there when auditing and other purposes are being met. So the training calendar has to be drawn annually. So it is related to the HIC protocols for the hospital and the healthcare organization and for the employees. And the training calendar has to be kept in a place where it can be clearly displayed. So the training schedule has to be known very well to the healthcare worker, so they can keep a track of what training they are supposed to undergo in the coming days. And HIC training calendar should be specific to the profession and the roles. And the need-based training is also required whenever there is an outbreak. So what are the requirements when we plan for a training? So once a schedule is being done for the group, so we need to create a circular with the particular things that have to be mentioned in the circular is what date the training is going to be, time, venue, what is the topic, who is going to be the target group, who is going to be the resource person. It has to be clearly mentioned, and the circular has to be displayed in a place where it can be accessed by all the healthcare workers. Very well advanced intimation has to be given to the group, so unnecessary leave or other things can be avoided, off duties can be avoided, so a good amount of attendance can be given. So if anybody is not able to participate because of genuine reason, they should be given another opportunity to take part so that the training doesn't get missed. Definite importance is to maintain an attendance record where mandatory the participant have to sign. Wherever required, practical and demonstration have to be performed. It is mandatory to conduct a post-evaluation. If training has happened, pre-evaluation also could be done. Feedback will help, which can be given by the trainee or by the immediate supervisor of the trainee, that ensures that how training has been effective for that employee. On-site monitoring and auditing has to be done, so it will help us in reinforcement whenever required. A skill observation of the training, it should be done so that we'll be able to identify how good the training has been translated into the practice. So there are various areas where a training has to happen in an institution for the staff, which is put in the training index. So one such area is the hospital infection control. So there are various topics which has been listed. This is our area of interest now. So what are the topics that have to be covered during a hospital infection control training? So the topics are hospital infection control committee. It should be about hand hygiene, which includes hand wash and hand scrub. All these topics have been covered by the previous speakers. What are the personal protective equipment, skill management, about needle stick injury, biomedical waste management. It should be about linen management, prevention of hospital acquired infection, pre and post exposure prophylaxis, patient care, equipments, respiratory hygiene, cough ethics, and water management. So when we decide and design a training schedule, it should contain very clearly what is the topic and who will be the resource person. So it could be an ophthalmologist or anybody who is involved in the hospital infection control. It could be the microbiologist and the hospital infection control nurse. The target group should be clearly mentioned. I have put in a few examples of our sheets from the training calendar. So color coding is one advantage. So we can easily identify which group and what kind of training has to be addressed in the coming days. So no training gets missed for any group. So this is the actual training. So the training which was planned, has it actually happened, has to be documented. So how many participants have been there, when it was scheduled, have to be clearly mentioned. So at times we need to scale up on our training as per the requirement. For example, in the month of March, when we had the pandemic of COVID-19, we had to address the whole employees, we had to address about COVID-19. So the topic about HIC, we had to expand more and get more of the other faculty. So that also could be done as per the situation. And what about the training material? So there should be a standard PowerPoint presentation with a standard details, and the content of the details should be in a descriptive way, pictorial. It could be in the video form or in the flow chart, which reaches the audience very easily. The language should be simple, clear definitions with protocols and guidelines should be there so that they can retain most of the things that are being taught. Also emphasize wherever required one-to-one training or group training. So it is mandatory, as I said earlier, to maintain an attendance where definitely the attendees have to sign pre and post. It could be in the language which is preferable by the attendees, so easily they can understand and they can replicate what they have learned. And the assessment evaluation have to be assessed, and the assessment has to be maintained, maybe confidentially. And whenever they are below the scoring, those staff have to be given opportunity to relearn it and then re-emphasize it, whatever they have missed. And these training reports have to be maintained for other purposes for when they come for auditing. Apart from maintaining a register about the training that has happened, the training what the employee undergoes have to be updated in their employee profile as well. It becomes important during their performance appraisal. Dynamic updating is required for each employee about what all topics they have undergone training. Of course, it is important to provide a feedback. It could be from the trainee as well as from the immediate seniors of the trainee, so that we can improvise the training based on the suggestions that are provided. Also, staff who are joining for the first joining new into the institution have to be introduced into the HIC topics through the induction training. I need to stress here on the role of the infection control nurse. So their role has to be in a well committed way for both for training and on-site monitoring. So all the topics are being covered, and monitoring has been done in every place. So any lacunae is there, it could be addressed then and there. So end of the year, when the training program is being summarized, definitely training for HIC also has to be done. So this will help us when you have a summary of what was planned and what has been actually executed. We'll be able to plan the next year's training in an effective way, so that it could be easily accessible, and it should be a target that could be fulfilled also. So to conclude, training for hospital infection control is the basic foundation for HIC. It has a definitive role for reducing nosocomial infection. Also, proper planning, execution, and evaluation and reinforcement are required for an effective training program. I thank everybody for their patient listening. Thank you so much.
Thank you, madam. That was a fantastic talk. Training is very, very crucial. Most of the hospitals who are aiming for the NABS, they have SOPs just for namesake. That is not what is needed. It has to be implemented, trained, and each and every person involved in the hospital infection control should, including the security as well as the cleaning person, should know what is SOP. It's not enough if you just keep it as a document and then don't follow it. Okay, what is more important now is the COVID, and our Haripriya madam is going to deal with it. And in fact, Aravind Eye Hospital was a role model for us, like standalone hospital. We were so confused what is COVID and what we should do, what we should not do. All those things, we people in Kerala, in fact, learned a lot of lessons from our dear sir's class we had during the COVID time. Over to you, madam, for that talk on HIC during COVID-19.
Thank you, sir. So I will be talking on HIC during COVID-19. So the standard precautions, as we are aware, to keep COVID at bay is physical distancing, face mask at all times, PPE as per the risk level, surface disinfection, and minimal contact of services. With all of these measures and protocols in place, the goal is to minimize the chance of spread. Of course, one is aware that we cannot totally prevent the spread. Now, this is what we focused on, but I think more recently we realized surface disinfection may not be as critical as it was thought in the past. As per this article from Harvard University's Public Health, they say that are we overcleaning in response to COVID-19? And the short answer is yes. And they say that with regular hand washing, there may not be a need to disinfect surfaces constantly. So I think that is something which we can take it a little easy on with the more recent knowledge we have. So having that knowledge, what is the aspects we have to focus on? Obviously on hand hygiene, face masks is very important, social distancing, and ensuring that identifying patients or staff who are COVID positive or COVID suspects so that we know to keep them at bay. So hand wash is critical, and I think we've had some great talks. So this is including the staff, the patients, and the attenders. So I think the chance of hospital acquired infections also is lesser now with this, not just with COVID. We see lesser incidence of ACCO as well. Probably this is attributed to the hand hygiene, which is being strictly followed in most places today. We are all aware of the importance of face masks for all the personnel, depending upon their role. In addition to face mask, I think the role of the slit lamp shield is also very useful, and shields wherever it's appropriate. Like in the counseling room also, we have this kind of a barrier here. So wherever we have whichever instrumentation we use, especially if you're coming in close contact with the patient, it's good to have this additional barrier to reduce the chance of transmission. The other question we had, initially we were asked not to use the non-contact tonometry because of the risk of aerosol generation. In the last month's issue of Journal of Glaucoma, there were two articles based on the safety of using NCT. The first article said that patients with moderately high or very high IOP tend to generate more aerosols. And the second article from India said that you have a higher chance of aerosol generation if the patient, if there is teardrops is higher, if the patient has just been applied with eye drops. So if we use the NCT for screening, which is what it is commonly used for, probably it is safer. Maybe it can't be used in a glaucoma clinic, but it could be used for general screening because the chance of having high IOP is lesser in those populations. Again, using NCT before dilation would be better, so you have less chance of generating aerosols. So we are using our NCTs back in Aravind for screening of intraocular pressure. The other aspect is social distancing and the importance of having well-ventilated spaces. As we are aware, the COVID spreads both with the help of droplets and aerosols. And with droplets which are smaller and also with the aerosols, you find that these tend to move more horizontally. And this spread could be even more than 2 meters, more than 6 feet. So that's why it's so important to stick on to whatever protocols we began with social distancing and using spaces which are well ventilated to reduce the chance of transmission. In terms of transmissibility, we realized that with COVID-19, thankfully the transmission is less than what we saw with what we see with other infections like smallpox or measles. On an average, one patient would infect about 2 or 3 other patients if you had COVID-19. But there's a lot of variation amongst the individuals in terms of how much they transmit. And some of the factors which determine the transmissibility could include genetics, the prior immune status of the person who is affected, and possible cross immunity for something else. So all of this would influence. So some patients could even transmit or infect about 10 to 11 patients if they have poor immunity, because they tend to have more viral load in their system. The other question we have is, are patients who are undergoing surgery at higher risk? Yes, they are at higher risk because one, patients who undergo surgery for cataract or glaucoma, they are one older and they also tend to have other comorbidities who are again at higher risk for both acquiring the infection and for having more severe infection. The longer duration the patient stays in the system and the more contact with the personnel also increases the risk of infection, both to the staff and to the patient. Moreover, the operating room is a closed space, so higher chance of transmission. The next question is, do we need to do COVID test prior to surgery? In terms of mandate, I think it is not mandatory to have the RT-PCR done for routine cataract surgery. But I think some states like Kerala do have guidelines where they say ask the patient, whether ask the physicians to have the RT-PCR done for all patients. So I think it is up to the individual practice. At Aravind, we do not do the RT-PCR test for routine cataract surgery. It is done for patients who have either symptoms or undergoing longer procedures like retinal surgeries or surgeries which can generate aerosols like sac and orbital surgeries, or patients undergoing surgery under general anesthesia. Again, if the patient has symptoms like fever, cough, sore throat, then the test is done. A CT chest can be considered if it is an emergency procedure, especially if the patient needs surgery under GA. Now, HRCT is not done commonly as a screening in many places because a lot of times you find that even after the infection has passed, there may be some persistent changes in the CT scan. So it is not being used as commonly, but could be investigation we could consider for screening in patients undergoing emergency surgery. In terms of checking if the patients have had COVID in the past, one is to see if they have any present symptoms. Second, if they have been affected with COVID in the past. And if they have, we want to know when did the symptoms start. So we know since when they have been asymptomatic and symptomatic, and if they were hospitalized. And if they were hospitalized, number of days they were in the hospital, and if they were in the ICU. Because all of this matters in terms of when we can take the patient up for surgery. So the CDC does not recommend retesting for COVID-19 patients within 90 days because there's a high chance that repeat PCR testing may still be positive for COVID-19. The American Society of Anesthesiologists have suggested that one can consider surgery in patients who were COVID-19 positive about 4 weeks after the patient had the first symptom. And this is true for patients who have had only mild symptoms. But if the patient had more symptoms and did not require hospitalization, about 6 weeks needs to pass. And 8 to 10 weeks if the patient was hospitalized, and about 12 weeks if the patient was hospitalized in an ICU. Now, these are more important for patients who require surgery under GA or retinal procedures, but also for other surgeries, this could kind of be a broad guideline which one can use. In terms of isolation, so one, in case someone has confirmed COVID-19, the CDC now recommends that the patient can be isolated for about 10 days following the day when the symptoms first appear. If the patient has more severe symptoms, then you can consider isolation for about 10 days to about 20 days. Earlier, we were having them in isolation for about 2 weeks, but now it could be about 10 days as per the CDC recommendation. Is phacoemulsification safe during COVID? I think we are all aware that most of our practices, we have restarted all our cataract surgeries, and this is because the aerosol which we do generate with phaco is not infected because this is mostly the BSS which is aerosolized, not the patient's fluids or aqueous, so it is safe to perform the cataract procedures. Regarding the algorithm of what PPE one can use for the different procedures, if it is a non-aerosol generating procedure and the patient has no symptoms, one can consider using level 1 PPE. However, if the patient has a high risk, the patient has symptoms, or if it is a surgery which generates aerosol, one can consider level 2 PPE. And if the patient is symptomatic, then level 3 PPE may be required. So most of the cataract surgeries would come under the category of using just level 1 PPE if the patient is asymptomatic. Level 1 would include surgical mask and isolation gloves, and level 2 PPE would be N95 respirator and disposable fluid repellent gown. A level 3 would also mean a negative pressure room and double disposable fluid repellent gloves and N99 or N95 mask. Besides what the operating room staff wears, it's also important to ensure the patient is also wearing a mask. Thankfully, because the patients are now used to wearing the mask at all times when they step out of their homes, most patients, I think, are comfortable wearing the mask during surgery. So it's fine to use mask during surgery. This way, you have an additional barrier. And another important aspect is also to use the tape. Now, this tape has two roles. One is if you don't have this tape, when the patient is lying on the table, we find the mask is loose, it tends to come forward towards the eye or tends to go back and the nostrils are exposed. So one, it holds it in place, but more importantly, it kinds of prevents the exhaled air from escaping from below the mask. And this is something which we have been doing for some time in all our hospitals, and this is a useful practice. It is simple but very effective. So just yesterday we had this paper published by the Dr. Vasavada's group in JCR. It appeared online yesterday, where they showed that with real-time imaging studies, if you have the tape, the chance of the exhaled air escaping is much lesser. So this is something we now have evidence that to tape the mask will help reduce the risk of leakage of the exhaled air. So this is something which we can consider not just for surgical patients, but also for patients in the outpatient area. So in the OP as well, we do this because again, one, it reduces the chance of leakage of exhaled air, also because you kind of avoid the chance of having any fogging of the during refraction or during 90D examination. Now, on the day of surgery, we would have the patients checked for temperature, and the hand rub is also applied. All vitals are checked. Now we have also ensured that all patients will do the pulse oximetry once in the block room, and again during surgery as well, this is being monitored. The patient is given a new mask in the OT, hand rub applied, and now we also have all our patients wear a gown over their street clothes. This has become mandatory now after the COVID pandemic. We also apply the povidone iodine twice, once in the block room and once in the OT table. And this we do know that iodine is extremely useful to reduce the incidence of endophthalmitis. But now we also have an additional indication now with the virus, with COVID also iodine is effective. So this is something which we would adhere to. So double application is useful. In the OT, we would have the patient again monitored with pulse oximetry, ensure the drape is placed well and it's sealed well, especially on the nasal and inferior side. In between cases, we have the theater cleaned, the OT table is cleaned, and all our staff now wear double gloves, and the outer glove is changed just in case there is a chance of contamination of the exhaled air with the glove. So we change the outer glove after each case, and the BMW is followed as per the SOP. So some of the changes are, one, we have the OT scrubs gowns, which are worn by the patient over their street clothes, which was not there before in the pre-COVID era. Second thing is one patient in the OT at a time. Now, most recently, about a month back, we have again started to move towards our routine of 2 patients in the OT at a time. And again, with the gloves, with the mask taped, I think that is not much of an issue today. And but our surgeons and our assisting staff do use double gloves and change the outer glove after each case. What remains the same is the perioperative antibiotics, autoclaving protocols, validation, surveillance, linen management, and BMW. We have had a great talk on education and training, so it's very important. End of the day, I think HIC is, whatever the systems we put in place, it's very important to have the human element also completely involved. So having a training schedule and a log is also very useful, and a mock drill also wherever applicable, so that if the whole team is aware and can ensure we have a good HIC system in place to prevent both hospital-acquired infections and COVID-19. Thank you.
Thank you, ma'am. That was a fantastic talk on COVID. During this time, it is very important. HIC is very, very important to control COVID. Now, if you look at the YouTube, more than 150 people have played back this video, and many institutions are watching them live with 30, 40 of them in the same YouTube channel. It is fantastic. It is a beautifully arranged program. Now we have a few questions here. Jayalakshmi madam is smiling there. She's going to get all the questions. The real expert in this field. Chandrasekhar, can you please put up the questions? And let me start with one question. Now the COVID, everybody feels that the severity has come down, the guard has come down. Even in Aravind, now we are having 2 patients in the theater, things like that. And if you look at Chennai, people are not wearing masks. Is it the right way we are going, ma'am?
So, so if you ask me personally, it is not. Of course, I do see the same. In fact, I was just mentioning to my team today morning that when last month, you would see Coimbatore had a good compliance of the use of mask. The universal masking was very well evident in almost all categories of people because there was a scare and all that. And now they were all worried. Post Diwali, we will have a huge number, and it was projected also that November would be very bad. December could go high again. So our second or third wave was going to come up. So there is a peak, and there's going to be much more complicated. And in the US, the numbers are high, and a lot of mortality associated. So a lot of things, and so people are much more cautious. And everybody now is well informed, and they are updated. So I think when they saw it not happening, I feel quite a few of them have put it down. In fact, I was worried for students joining back classes because medical colleges have started from December 7th, and they started having regular classes with the, of course, distanced placement of students, and having their clinical activities happening, all of these. So it is not a good sign that we see. Till we get rid of it completely, I think we should continue to, because if it was not so very bad, why would some colleges where multiple sharing accommodation would have so many numbers again? So why would we go back to that increased numbers? So definitely, I think we should continue to wear our guards as long as we've been advised to, and it is definitely not so very bad. But the presentations are different, varied. There are a lot of studies. People are telling a lot of varied presentations of the same, and the numbers being asymptomatic is also there. So I think it's good to continue with the mask. Yes, sir.
This message has to reach everybody, madam. Even in hospitals, the paramedicals, they are feeling that everything is over. Sting vaccine is already come into.
I thought I should add that.
Coming to an end. But in US, the things are becoming very worse. Then in UK also, there is a research with a new strain. So we'll have to keep our guards.
Definitely, sir. Yeah, because the vaccine, the news about the vaccine, the use about the vaccine, prioritization of vaccine. So all of these things have also made it a little bit not so very, because people have so far behaved based on fear. Studies have shown that even the use of personal protectors or the HIC practices were at its peak in the initial 1 or 2 months, and slowly they started to, because they started to see that this is how it is and this is how we handle. And when it became lesser, I think the practices again came down. May it be just PPE use or even hand hygiene, distancing, everything. Sir.
Thank you, madam. Now, Chandrasekhar, do you have any questions?
Yeah, Rajiv, just to add to your point, I think we are shortly reaching 1 crore population in India who are going to be positive. But if you look at US, their death rate is 1,000 per million, whereas we are only 100 per million. But some of the studies have showed our prevalence is very, very high. Many have gone asymptomatic. So the good news is the mortality is very low, but we are still not done with COVID because there are many untouched areas. So we cannot risk anything. Even now, the status of vaccines are not clear at all. There are varying reports, and UK reports multiple strains now. So we have to go on till we have a long-term outcomes measure of these vaccines. We have to be on guard. That is what I also feel. Yes, Rajiv.
And people who have recovered also have been symptoms for a very long time. We don't know the long-term complications of this COVID. So it's better that we keep our guard tight.
Yeah, true, sir.
As far as COVID is concerned.
That's
okay, right. Madam. And one question I've got is the settle plate method. How exactly it is done?
So settle plate, ideally you should place them 1 meter away from the wall, 1 meter away from the floor, and for 1 hour. Okay, there is nothing like this is the only way to be done, but this is the way that has been described. Okay, this is for looking at the contamination in the air. So it's for air surveillance. And this is for areas, you can use it anywhere, but if you're using it in the theater, ideally you should use 5. At least 4, which means 4 corners plus 1 closer to your OT theater. And then count the colonies, and you take you divide it by the factor 4 so that you get the actual numbers of colonies for 1 hour of exposure. Okay, sir. So usually we choose one culture plate only, which is the blood culture plate, because it can get most of the organism, the fastidious and non-fastidious, both of them would, but it has to be placed properly. And the persons also should keep it in such a way that it is exposed. Sometimes they keep the plate and remote and come. You will see that it is closed. Okay, so that's a very technical issue. And the person who's allowed to go inside is only a person who's draped in a OT gown. So the technical person from the laboratory sometimes says, "Idu vachittu eduthu kuduthirunga. You keep it and give it back to me in 1 hour." So where did they keep? Did they keep it for some time? Did they open it and then did they come back? So those things are not there. But it also we'll have to look at when do you want to keep. So there are 2 times. One is before any surgical procedure is starting. So it is an environment where it is calm. There is no air turbulence. Okay, there is nobody moving in and out. There is no floats or the skin flora of anybody, any person who's walking in the environment. In such an environment, you can have a number less than or equal to 30 colony forming units in a routine theater. But for a ophthal theater, you can go a little lower. 1 to 10 would be the ideal. Actually, for an ultra clean theater, they'll say 1. 1 when you are not having, that is 1, lesser than 1 means almost 0. That is what you should expect for an ultra clean theater where you are doing a transplantation procedure or implant procedure or a cardiothoracic procedure. In such theaters, in an empty theater. But even in such theaters, during procedure, there is an amount allowed, that is numbers allowed to be slightly higher. About 150 colony forming units can be allowed in a theater where people are working, because when people are working, there is always an increased number of flora. Okay, but it cannot have more than that in a routine theater. So you in an ophthal theater, you should have it as low as possible. 10 colony forming units is what a lot of literature would also mention. So that is all you should maintain for a working theater. So that means you should have a good system of removing the air from the theater, having a good air exchange happening. The number of air exchange happening within 1 hour has to be more, that is 20 to 25 is for a routine theater, or more than that should be there for you to have a good load of good fresh air coming into the system more. And then there is flushing out of the organism. Now what is good about these ophthal theater is that the area that you open for your procedures are very small. Okay, your site that you open up is, so there is not much of contamination coming from the patient or from those infectious material coming from that site. But what is happening from a patient walking in, if not washed well, not given instruction to the patient very well, and when you're doing in camps, when you have them brought in, they would be walking in, so there may be dust and dirt coming in also along with that. So that may increase your load, and the type of organism also would be very different in those environments. Ma'am, Lalita ma'am, is there anything you would want to add?
Yes, ma'am.
No, Dr. Jayalakshmi, that was beautifully, you described everything. So
Madam,
I think that's
you mean to say that when you put the plate, the air conditioning system should work?
Yes, sir.
It should be on. Okay. Most of them keep it off and then
off. Yes.
That's wrong. The circulation, the air circulation
correct,
should be there.
You also have those air samplers, and air samplers should be held in positions where you closer to that and you allow the amount of air through with a plate for a defined period of time, and then count the colonies. Again, the plate would be the same, incubation would be the same. Looking for a type of organism definitely matters. In ophthal theaters, you should look for fungal contaminations for longer, nocardial contamination for longer, all of these. So you may have to keep it for a little longer time than the routine in any other surgical theaters. Yeah.
Do you need a special plate for fungus, madam?
Yes, sir. A Sabro's dextrosigar would be ideally kept. Blood agar would keep, but you have to keep it for longer time. So you have to be very careful that it is not picking up any other contaminant from anywhere else also. So that is the only challenge that we would have.
Is it proportionate to the time exposed, madam? The number of colonies?
Yes, 1 hour. Yes, sir. Yes, sir. It's 1 hour. There is a calculation I can share with you later. Maybe I can put it up. There is a calculation depending of the exposure. You can also calculate. You can even keep it for 15 minutes, 30 minutes, or 1 hour. And depending on the exposure time, the colony counts will also be varied. Yes.
Madam, keeping this air conditioning on, for AHU, it is okay. Even for split ACs, you would advise keeping the split AC on for this settle plates?
Yes,
Sir, actually, split AC is not an ideal at all, first
But
of
some
all.
entry level we have, madam.
So, yeah, but so you have to maintain it also because it maintains the temperature and humidity and the moisture within the system. So, it's always preferred to have it on, sir, to see the actual working condition. Yes, sir.
Now, I'll request Dr. Lalita, madam, to ask any clarifications from eye hospital point of view.
Ma'am should be able to answer.
No, regarding our hospital, some of the things we would be able to clarify, isn't it, madam?
Anything.
Actually, Dr. Rajiv, is there any other questions in that YouTube, which is any repeated questions?
No, madam, no.
And there's no other question.
There is one question.
Okay.
How is sodium hypochlorite 1% solution prepared?
Okay.
It's a very practical question. No.
So it depends on what are you buying. You could buy 4, 5, or 6%, depending on your availability. The most often available is 5%, I guess, and now also is available is 4%. There used to be an availability of a 10% earlier when the biomedical waste rule was mentioning the use of it in 2016. Okay, when it got amended in 2018 as a typo error, the 10% became 1%. Actually, it was 1% only, which was by chance and a typo error that a zero added to it. But because it was given in a government document of biomedical waste rule, it was made available. A lot of places were using 10% sodium hypochlorite and still available also. So depending on your stock solution of your sodium hypochlorite that's available with you, your 1% preparation also will vary. So if it is 4%, then it will be 1 and 3 dilution. So you will take 25 ml and then 75 ml would be your. So you can make markings. So the best way that you could do is have a measuring jar, add it into a regular bottle or a container, and mark line can be made. So if they have to prepare 1 liter of it, the mark line can be made for the concentrated solution. The rest of it can be filled with water, shook nicely, and then used. It's almost like making a juice. Yeah.
Madam, from bleaching powder, it can be prepared. Is it advisable?
Yeah, you can prepare, sir. It is allowed. In fact, NACO will give you a guideline of the same, like you could use. It is 3 teaspoons or it's 15 grams in 1 liter of water. So what is advised to do is take 3 teaspoons of bleaching powder, mix it with 10 ml of water. Why? Because it will be, if you allow it to just put directly, they just form lumps in the water. It will not mix. So put them and mix it very well so that it becomes like a paste and then solution. Then add the 990 ml completely and you shake well and you can use it. This is fresh. It can be used freshly. And any sodium hypochlorite, 1% sodium hypochlorite, wherever it is prepared, it cannot be used for more than a day. Okay, so there are some actually it requires only 0.1% for you to kill these the viruses that we are worried about, because most of these enveloped viruses die easily. So you don't have to worry as much. But when you start with a start solution of 1%, by the time the end of the day comes, even if there would be a dilution happening or even if the deterioration of the component, it still works. So that's the logic behind it, sir.
There is one more question, madam. Everybody says freshly prepared. What do you mean by this freshly? How long you can keep this solution?
That's what, sir. Not more than 24 hours, sir. 1 day. 1 day,
Oh.
yeah. And prefer to close and keep. Don't keep it open. The more oxygenation it loses.
And madam, one more question. Is it that sodium hypochlorite is now not preferred decontaminant?
Pardon me, sir?
Is it now not a preferred decontaminant? Because when I
no, sir. No, sir. It's still a good decontaminating. It is very effective, sir, on the routinely worried microorganism. It does work very well. Only thing is, depends on the surface that you're using. Your surfaces, if they are metallic surfaces, if you clean with the sodium hypochlorite, they will soon rust and they will lose. So ideally, choose your disinfectant solution for cleaning surfaces based on what are the surfaces. You choose your disinfectants. You can use any disinfectant, sir, for standardization. If you see the CDC, WHO, or the NCDC, ICMR, all of them clearly mentioned use of sodium hypochlorite or alcohol for cleaning, or a phenol when it would be on the walls and floors and in the restrooms for cleaning. But they focus most on the sodium hypochlorite and alcohol. If it is a non-metallic surface, you can use a surface cleaning with alcohol-based solution. And if it is a metallic surface, I'm telling the reverse. The metallic ones and others, everything you can use alcohol. But for the metallic, you choose not to use the sodium hypochlorite. But if you look at the CDC, it will give you a list of disinfectants which are approved for use during this time. And in fact, they have allowed certain disinfectant to be used even as a emergency use authorization. EUA is what they call it. EUA, that is emergency use authorization. During pandemic times, there are a lot of things that will be allowed to be used which are not routinely recommended if they work also. So like how we use our masks and all of that. Yeah.
No, because when I was going through the guidelines, more than the efficacy, I think there was a worry about chlorine being used. The bags are already non-chlorinated.
Yeah. So now what is happening is lot of sodium hypochlorite being used and prepared and thrown into the environment. So there is a change. So slowly they would want to have a lesser. In fact, if you see the biomedical waste rule, it would say slowly the use of sodium hypochlorite is not been recommended either on your disposed plastics or sharps, etc. Only area it would say that you please use 1% sodium hypochlorite is when you're wanting to decontaminate your liquid waste, which are coming from your laboratories, dialysis units, your theater or CSSTs, wherever you have a high load of organism and blood and body fluid being contaminated. So those are the only fluid, water or solutions, or the mop solutions, the floor mop solutions, which have to be thrown into the drain, but it has to be decontaminated and thrown. And that goes to the ETP. Okay, so it has to go into an area. I think it was described, I think I just peeped in during one of the time that for a liquid waste, you have to use 1% sodium hypochlorite for a half an hour contact period and then thrown into for an ETP. Yeah.
Thank you.
So even your bags are chlorine-free or non-chlorinated bags are being used because you don't want to burn these chlorinated bags, because yellow bags goes into for incineration directly. And the red bags you should not be incinerating because of the dye that is there. And when you burn them, you release a lot of toxic fumes, digoxins and furans. So these are not good for the environment. So usually you do not put anything into the red which need to be burned. So it goes into the yellow, and non-chlorinated is one. I think in the presentation that had the biomedical waste, the cardboard box with the blue line is 2016 and guideline, and in 2018 when it got amended, it was removed. I should say that we've been using such cardboard boxes which are very, very useful in our setups. When I was in PhD, we used to use these boxes, and I used to use these glove boxes which used to be blue in color, and I used to teach everybody to see the seams to be fixed with the micropore and put a label saying that for sharps only. So because ampules, when you break, older guideline you say for sharps you put in a punch-proof container, but the mouth would be so small. How do you take the broken glasses and put inside? So what I would tell them is to have those boxes, seam them all, seams been sealed very well, and use them. So in fact, the first few times when we had assessment, they used to say, what are you guys doing? Is it there in the recommendation? But in 2016, that became a recommendation with the cardboard box and the blue lining on that. But what it did not describe is how to use it. So people, when they started to break ampules with solutions and throw ampules which are broken with the solutions left over, and when seams are not fixed at the bottom, when they take the cardboard totally up, everything drops down. So it was a failed one. So what they did in 2018 was they converted that cardboard box into a blue punch-proof container.
So,
I should say, I think the entire team said they did fantastic session, I guess. It was wonderful. All the ophthalmologists doing great infection control sessions. It's really nice. So I don't think there's much question. They're all experts.
I have a question which I like to throw open to all of us. Madam, in the similar context of carryover, historical carryover of regulations in the biomedical waste, is the current confusion regarding what do we do with needles. I know for a fact that most hospitals are not cutting their needles. And I think that is simply a historical carryover. It was earlier when the fixed needle syringes as well as other syringes were, willy-nilly being thrown everywhere. Was a requirement that we need to hub cut it or cut the needles and then dispose it on site.
Yes.
But over the years, my current interpretation is that even though the biomedical waste 2016 and 2018 have a very confusing clause, if you read it, it says and or and all kinds of stuff. My interpretation is that if the occupier or the waste generator has a proper linkage with the aggregator or the collector and disposed in the appropriate manner, that needles can be disposed directly into the sharps container and no needle cutting needs to take place. What is your take on that? And is there, what is the, conclusion on all this?
Yes. So the guideline says you have to cut and dispose. The guideline says you have to cut and dispose.
Yes.
Okay, sir. So if you are able to, if you have a system of sharps collector, which cannot be removed, it cannot come out. Okay. In such a system, you can drop along with a syringe also. That is syringe with the needle, particularly if it is a Mantoux or your insulin syringes. When they're fixed syringe and needles, you can directly dispose also. So this is like a gray zone that you have. But if you look at the guideline, it clearly says you have to cut the needle. So why is this mentioned? Because the guideline is common across the country. Not just in places where we all know how to use, but it's also to those rural areas where the last person who's using the needle should know that they are supposed to be reused. So they recommend that it gets cut. Earlier it used to be burned. Now no burning. It's only cut with the hub being cut off. So that the needle cannot be used, the syringe also. So the idea was not to make it not usable again. Reused, cannot be reused.
I understood that. But are you saying that all of these hospitals are actually cutting their needles?
Should cut, sir.
Okay, sir, I'll add a point to this. The NABH HOPE application asks very specifically for cutting of needles. Why no burning? Because that causes toxic material.
Fumes.
So no burning, it causes fumes. So we have to upload the cutter in use and the cutting of needles. As madam said, only those which cannot be detached from the syringe can be put directly. That is a requirement, sir, for NABH. And NABH goes by BMW rules only.
It's a rule of the country. So it is almost like, in fact, the 5th edition and NABH, they removed all the objective elements. It used to be as 5 different objective elements for under HIC 8. They used to have 5 objective. Now they said, okay, just follow that. Okay, just do it properly, your biomedical, because they know it is a rule and everybody has to abide by the rule. That's it.
Thank you.
Madam, Haripriya madam or Lalita madam, would you ask anything?
I just wanted to know your take on should we test the consumables we use, like the BSS and viscoelastic? Is it recommended routinely to do a culture or the pH? Considering one, we may not know the manufacturer's standards, there may be issues with storage, issue with transportation. So is that recommended?
I mean, depending on the type of consumables, ma'am, if you're going to place something internally, okay, if it's coming sterile, why would you want to open it and then culture it and then use it? But if it is going to be coming in a bulk and you're going to use it, okay, internally, then you will have to at least one, as a sample. But it is not a must that you have to culture everything, ma'am, unless sometimes the site and the fluid is being tested for. You take a drop of the fluid, whatever was used on the patient to test for, but you don't take the consumable as such and see before use, I won't want to swab and see or check and see. That is not really required. And if you know it's coming in a sealed pack, saying it's sterile, you just believe it is sterile.
So I think in ophthalmology, we have all this issue with irrigating solutions.
That's what, ma'am, that you have to put for culture.
Yeah.
You have to put for culture. That's what I said,
So
but not what you purchase. Yeah.
Yeah. So what we purchase is what I'm asking, because sometimes even if it was sterile pouch, there may have been some damage during transportation. And we have seen issues like that. So I just want to know the consent.
So once you open it, ma'am, it's no more sterile. So what you do is when you're opening it, use it on a patient. Same thing, you put it on a plate. So I have heard this. This I'm telling you by an experience with an ophthalmologist that we had, who used to put it up, and we used to do the culture for them. So once they are doing those procedures, after using it on the patient, the same thing would be dropped on. You can just put 10 microliters in drops on the culture plate, and that would be incubated to see whether there is any organism growing the next day. If there isn't anything, that you don't have to worry about, so you're very sure of your solution.
At Aravind, we do like one per batch. So one bag per batch, or one bottle per batch, or one viscola. That's what we do as well. I don't know. A house in Kerala, sir. I mean, do you?
We normally see. It depends on the incident. Like if we have come across or we get a message that a particular batch has got some, only then we do the culture. Normally we don't.
Normally don't do it. Okay.
Because the volume I do is far less than what you.
When you know that the batch is contaminated, you don't use it, so don't culture them at all.
Madam, actually, I've seen this practice where we see one sample testing. Unless we get the culture, we do not put it into circulation. Many of the hospitals don't do because of two facts. Here we have our own microbiology department, so we are at liberty. But when they have to give it outside for every batch, it is pretty expensive, madam. So actually, routinely, many hospitals don't do.
I think
it's really not required unless you have had an experience of this, or so a lot of solutions have. I mean, lot of case studies are there with ophthalmic solutions going in for having contaminated solution leading for complication. Those are all there. But once you get your one whole batch and one whole lot, you can maybe test one sample if you had a past experience of that. But I don't think it's really a must, because you trust those solutions to be sterile and then you use it. Unless you're going to use for multiple patients on the same time, then between patients you want to see whether there is a contamination. That's when you want to take these fluids and use it and see whether it is still useful. Because once you open, no more the pack is sterile.
What is most important is the integrity of the packing. If the packing is damaged, you don't rely on that.
Yeah.
It's what I personally
look for the expiry, and then if it's dirty also, not if it's dirty or if there is a small breach anywhere. So it's good to train our people to look and inspect these packs before even they employ it for use or deploy it for use.
That is important to look at the packing, and we also have this black and white chamber. So we keep our bottles, if we use bottles, in that chamber to look for any floating particles. That with that we kind of can pick it up grossly as well.
So there is always a fear that you're introducing into somebody's eyes, and you want to be very careful. That was wonderful.
Madam, Lalita madam, any questions?
No, sir. I think this is a very, very interesting discussion going on. No, I don't have any specific questions.
And, actually, we are past time.
Yeah, that's what
I'd like to thank all the panelists, Dr. Rajiv, Dr. Kalpana madam, and Dr. Jayalakshmi. I think now everybody will understand why Dr. Jayalakshmi is an authority in infection control, and she holds advanced CPHIC 2-day programs, madam. It is absolutely mind-boggling if you see the material, and at least a few people from our big hospitals can join that. They will get a clearer view about how it is. So all the speakers did a wonderful job, and the panel discussion was even better. So on behalf of our CMO, Dr. Aravind sir, I'd like to thank each and every one of you and all those people on YouTube for joining us for this webinar. Thank you so much, all of you. Thank you so much.
Thank you very much, sir. Thank you for inviting. Thank you very much.
Jagdish, offline pilla.
Okay, Chandru.
Yeah. Thank you. Just 1 minute. Okay. Thank you so much.